Hi everyone. I think I look very smug and pleased with myself because I'm at a standing desk for the first time in my life. It's not mine; it's just borrowed. But yeah, I'm feeling good and ready to go. Happy Tuesday, everybody. I hope you've all had a good day so far. Welcome to the live chat of Probably Nothing. If you are watching live, welcome. Thanks for joining me. If you are watching on catch up, because we always record and post the episodes after they've finished recording live. If you're watching on catch up, thanks so much for taking the time to catch up with what we're chatting about. So my name is Karen. I will predictably make the joke I always make. Please don't let that put you off. I promise I'm a nice Karen. I am a proud ambassador for the Eve Appeal and host of Probably Nothing. So Probably Nothing is the Eve Appeal's weekly live online chat show where we talk about a particular subject related to gynae cancer. We're in series 8 now, and we've covered anything and everything from signs and symptoms, risk factors, barriers to screening, how to check your vulva, you name it, we've discussed it. We started Probably Nothing in June 2020, so almost 3 years now, after our Ask Eve service, our free information service run by wonderful nurses Helen and Tracy, was getting lots of questions from people saying, it's probably nothing but, and then they would explain their gynae concern. And whilst most of the time that probably nothing is true, most of the symptoms of all the gynae cancers, for example, are more likely to be something less serious than cancer. Sometimes, for some people, that probably nothing is actually something. So we wanted to create a space where, in an accessible way, I can chat to an expert, a guest, someone with a lived experience each week, and share information, share knowledge, and hopefully help answer your questions. So I always say I'm going to do a quick intro. I never do. It never happens. Hasn't happened in 8 series, isn't going to happen yet. So series 8 is focusing on womb cancer with emphasis on postmenopausal bleeding, which is one of the main symptoms of womb cancer amongst the Black and Asian communities. Now, we're focusing on this topic in these communities because we're working with the wonderful North East Cancer Alliance at the moment on a project called You Need to Know. And this is based on results from research in 2018 showing that in this part of London, Black or Asian women is much more likely to be diagnosed with a stage 4 womb cancer than a stage 1. So stage 1 is early, stage 4 is a late diagnosis. There is no stage 5 in cancer. And we know from other research that Black women have a higher incidence and mortality rate when it comes to womb cancer. So we're working with the North East Cancer Alliance to give talks to different communities, different groups, to reach the people that need the information. Last week was episode 1 of series 8, and I spoke to the wonderful Dr Aayushi Pandya, an NHS GP, and I spoke to her about the signs and symptoms of womb cancer, what patients can expect when they are potentially worried and go and see her as a GP. So in episode 2, this episode, I'm speaking to a gynae obs doctor about what happens when somebody is referred to her from their equivalent of Dr Sisse. So from their GP, what happens if you are sent for a referral with suspected womb cancer symptoms? So I'll bring my wonderful guest in now. I'm sorry about the long intro. Come in, Dr Aayushi Pandya, an obs and gynae doctor. Welcome. Please tell us a bit about yourself, and I'm sorry again for the long intro.
No, I loved the long intro. Thank you for having me here. My name's Aayushi. I'm an Obstetrics and Gynaecology doctor working in East London under Bart's NHS Trust. I'm passionate about treating women with gynecological cancers, and I firmly believe that one of the most important parts or aspects of treatment is catching the disease early, and that all comes through education with wonderful initiatives like this. So thank you for letting me be a part of this.
Oh, You're a star. I can tell we're going to have a really good chat. Thank you so much. So let's get straight into it. So as I explained in the never-ending intro, I'll never live it down. We spoke last week about if somebody is worried about potential symptoms, we went through all of the symptoms with Dr. Se8Ep2, they will see her, and if she thinks there is a concern, a possibility of womb cancer, she will refer to a gynae doctor, refer to hospital for further investigation. So let's kind of go right from the beginning. How kind of, I know I would worry about this, and I know viewers will worry the same question. Let's cut straight to the chase. If somebody is referred to you from their GP because they have potential womb cancer symptoms, is it likely they are actually going to end up with a womb cancer diagnosis?
So I think that's a very good question. Like you've mentioned, the most common feature of a womb cancer is having postmenopausal bleeding. So this is any vaginal bleeding after 1 year of not having periods. Now, in 10 women with that symptom, only 1 will be found to have womb cancer. So 90% of individuals with postmenopausal bleeding will have that because of another reason that isn't necessary cancer. However, if you take 10 women with womb cancer, 9 of them would have had postmenopausal bleeding. So it's important to be mindful about it, but to know that there are lots of reasons as to why they could be having this symptom as well.
Of course. So it's like, please, obviously, as we keep begging people, if you're able to report your symptoms to the doctor and start this process, but don't go into the appointment convincing yourself that it's a cancer diagnosis.
Exactly.
So somebody comes into you, they have, say, postmenopausal bleeding, they've been referred to you. What would be the first thing that would happen? Like, would their first appointment, their first referral after seeing their GP, would that be an immediate test or scan of some sort, or would it be talking to you first and then you decide what the next step is?
Yeah, definitely. So similar to what they may have experienced with their GP, we would want to see them. We would want to have a chat with them, find out exactly what's been going on. Have they been having any other symptoms? Is there anything that could explain the bleeding that would kind of reassure us away from a diagnosis of cancer? We would also want to do some kind of bedside examinations on them, like they may have done at the GP. So having a feel of their tummy, seeing if I can feel any mass or anything obvious, and also doing an examination from down below. So using a speculum, so a plastic device through the vagina, just to have a look at the neck of the womb and to see if there's anything obvious there. They may have had these already done at the GP, but it's important for the hospital doctors as well to do those when we meet someone.
I don't know if people watching this will have thought of this question, but I really want to ask this because it's just been scratching at me. So Aziza and I spoke about how, understandably, sometimes people aren't able to get a face-to-face GP appointment, and it might be on the phone initially. So, but because postmenopausal bleeding is taken seriously, Aziza and other GPs would quite potentially speak to a 68-year-old on the phone, hear that she's bleeding, and refer her if they aren't able to see her kind of pretty quickly. So by just speaking, if somebody comes to you with postmenopausal bleeding and they haven't been vaginally visually examined by their GP, they're just going from a phone call, would that affect how you kind of start the investigations? Because would you maybe think, because people kind of follow Eve, we always harp on about abnormal bleeding, it's a sign of cervical and vaginal cancer as well. So would you maybe think, oh, we need to check all 3 rather than just womb,
Yeah, so I think it wouldn't necessarily change what I would do seeing someone for the first time in a clinic. The GP referral, whether it's over through a phone consultation or a face-to-face, both are equally valid because both have been created or raised because of that symptom of postmenopausal bleeding, which we do take seriously. So if I'm meeting any woman for the first time and she's come in with this symptom, I would take the same steps. I'd want to have the conversation with her. I'd want to examine her by the bedside externally and also perform the investigation, like I said, using a speculum too, because it's important that we see what we can visualize before we arrange further investigations, such as ultrasound scans and other camera tests as well.
Okay. And obviously the person is with you because they've reported potential symptoms. Is there, I know we're kind of focusing on postmenopausal bleeding, but obviously we know that any gynae cancer can happen whatever decade, you know, of your life you're in. With the sort of postmenopausal, you'd be seeing these people hopefully on the 2-week referral pathway, right? And if somebody is, say, 35 but had really odd bleeding patterns, it's just not right for her, what sort of is the difference in timings between GP and seeing you depending on postmenopause or premenopause?
So with postmenopausal bleeding, it does kind of initiate that 2-week wait pathway, like you've said. Any other abnormal bleeding, it is up to the GP's discretion as to what sort of referral is made. The likelihood of suspicion that it could be cancer or something else, the impact it's having to the woman. For example, if she's in a lot of pain, if she's bleeding quite heavily and is anemic, these would be things, so having a low iron level, these would be things that would expedite the woman then seeing us. So there's a whole kind of range of factors, including other medical conditions the person may have, whether they're trying to have a baby, whether this is kind of impeding their progress with that. So I think the GP has to look at a whole range of different factors and make the referral to us. And then we do prioritize women based on need and what we can do.
Okay, thank you. So you've spoken about having a look with a speculum, having a feel. After that and the initial conversation with you, what, if you think, okay, we need to get investigating, get our thinking caps on, what would be the first or next step after the chat and the speculum?
So the next step, our kind of gold standard investigation, would be an ultrasound scan. And this would be a vaginal ultrasound scan. So we would use a probe about the size of a finger, insert it into the vagina in order to have a look at what's happening inside. And this is especially important because what we want to do is measure how thick the inner lining of the womb is. We say that if the inner lining of the womb is kind of less than 4 millimeters, it's very unlikely that it will be a cancer. However, we're more worried if it's greater than 4 millimeters. So we could arrange other investigations at that stage.
And if there's the sort of the thickness, whether it's a cancer or not, depending on your age and whether you're pre or postmenopausal, is it more likely that me in my early 30s would have a certain thickness and someone at 65, regardless of our cancer status, would have a different thickness? Does it get like thicker or thinner as you age?
Yeah, of course. So I think if a woman is having those monthly cycles, then the thickness of the lining of her womb would be changing because it would shed in order to have the period and then kind of build up again, so to speak. So we do have different measurements of what would be normal, depending on whether the woman has gone through her menopause or not. But our general number for postmenopausal women is 4 millimeters. If there is a woman and her ultrasound shows something greater than 4 millimeters for the thickness of the inner lining of the womb, then we would arrange an investigation called a hysteroscopy, which is essentially a very narrow telescope, so to speak, with a light and a camera at the end. This would be inserted through the vagina, through the neck of the womb, and would allow the doctor or the clinician to have a look at exactly what's going on inside. No cuts would be made. It's using all the natural openings that a woman would have. And if anything was seen that was abnormal or worrying or suspicious, then we could take a little sample as well of those cells in the inner lining of the womb to have a look at them under the microscope and give some clarity as to what was going on for the woman.
So when having the ultrasound scan, the first point of investigation, if somebody is 65, has postmenopausal bleeding, but they're lining on the scan is kind of under the threshold of concern, would that person sort of be told, you know, come back if the bleeding continues and we'll do other investigations? Or is it kind of, that's just life for her now, she just has bleeding? Or, you know, if she doesn't kind of warrant the hysteroscopy because of the thickness, what would happen to her if she was, say, 3 millimeters thick but having bleeding?
So I think it would depend on any other symptoms the woman was having, any other risk factors that she may have. Ultimately, the only conclusive way of giving reassurance to someone that something isn't cancer and isn't concerning is by doing the hysteroscopy and by getting a sample of those cells. So I think independent, obviously the ultrasound is very important and gives us an idea of how suspicious we should be. But our kind of definitive answer, so to speak, would be through the hysteroscopy and taking a sample of cells, so something called a biopsy.
Okay. And in the hysteroscopy, is it like a long procedure? Is it as quick as a cervical screening or smear test, some people refer? You know, is it, are you put to sleep? Are you given pain relief? What's it like?
So
have you had one? May I ask, have you ever had one?
So I've not had a hysteroscopy. I do hysteroscopies. I've not had one yet. But essentially, it would take longer than a smear, but not that much longer. A hysteroscopy can take about 5 to 10 minutes. So it still is a very short procedure. Most of these can be done as what we call an outpatient procedure, where the individual is awake. They're given pain relief in the form of tablets. Sometimes we may give a bit of local anesthetic, but most of these, because they're so quick, they don't require being put to sleep or a general anesthetic or anything like that. Some women, if we see something, if we see a growth in the inner lining of the womb, something that we feel that we need to remove, or if someone actually just can't tolerate having it done when they're awake, because even smears, like I would say, a smear is not a comfortable experience. It's something we have to go through, but it's not a comfortable experience. So I definitely appreciate that some women would prefer having a hysteroscopy when being asleep, and totally advocate for people to make that decision for themselves. With that, it would still be a day case procedure. They'd come in the morning, and they'd be able to leave before the end of the day. They wouldn't need to stay overnight. And essentially, it'd still last the same amount of time. But I guess because the individual would be asleep, we wouldn't be pausing in case they felt anything, if that makes sense.
Yes, it does. Thank you. And so you've said that the hysteroscopy and taking a small sample or biopsy, if needed. So not always. Some people might have a hysteroscopy and just that, but sometimes a biopsy as well. If somebody has a biopsy taken, how long? Because I'm sure you'll agree, and kind of see this from people every day, waiting and kind of not knowing what your results are almost worse than the physical appointments. They can drive us mad, can't they? Is there a rough timing, or is it kind of just as and when? Is there sort of a time scale that you try and get biopsy results from a hysteroscopy back by, because of the nature of what we're trying to rule out?
Yes. So if we were to take a biopsy from a hysteroscopy in a woman with postmenopausal bleeding, we would send it off to the lab under the 2-week wait pathway. So we would try and get those results within those 2 weeks and arrange to either speak to the woman on the phone afterwards or see her in person after those results. So it still would be within a few weeks, as you said, because of the concern of having that symptom. I think, as you've mentioned, there are a lot of women that have the hysteroscopy and no biopsy. I think that's a really important thing to say, because, like we've said, there are lots of different reasons as to why women could have postmenopausal bleeding. And the most common one is having something called atrophy, which happens after your menopause, where actually everything becomes very, very thin. The lining is thin. There isn't any way that we can take a biopsy. And I think that's reassurance enough for the woman just by seeing that. from us with the naked eye, looking at the camera images and realizing, no, we don't need to take a biopsy. We can't take a biopsy here. And the woman can get reassurance from that.
Yeah, that must definitely be very, excuse me, very reassuring. You mentioned, if the lining is thicker, then it sort of activates, okay, we're going to do a hysteroscopy, potentially biopsy. Obviously, it's not super likely to be womb cancer. We still want to encourage people to go, but it's not, okay, this is it, this is what it is straight away. What are the other things that could show a thickened womb lining other than a cancer diagnosis?
Okay, so there are a few different things. There is something called hyperplasia, which essentially means thickening or an increase in the number of cells in that area.
Like they've gone hyper and
they've
grown too much. Yeah.
Out of control.
Yeah.
And there are other non-cancerous growths on the inner lining of the womb called polyps. And these can be removed in the same procedure when we do the hysteroscopy. We just remove it. Sometimes it's like a little ball on a stalk that we can see kind of jutting out, and we're like, oh, let's just take that away. That was the cause of the bleeding.
So you just know, just by seeing it when you're doing the hysteroscopy with the little telescope, you just think there's a polyp, let's take it off. It's kind of not, oh, what is that? You know when you know.
Yeah, so we see the polyp, we feel reassured, we always send it off because we can't be certain without kind of having a look under the microscope. With the hyperplasia, as I mentioned, I think that's a bit more nuanced. So I'd like a couple of minutes to talk about that.
Yes, please, please.
So essentially, there are two different types of hyperplasia, and one of the types is called atypical hyperplasia, and one is hyperplasia without the atypia. So when it's without the atypia, we're more chilled, we're more relaxed. Essentially, getting this diagnosis means that over a course of 20 years, that individual has less than a 5% chance of this becoming a cancer.
Okay.
So it is very reassuring. And the majority of those, the ones without the atypia, they get better on their own.
And is it common to have hyperplasia in general? And is hyperplasia without atypia a common thing?
So in terms of women that present with postmenopausal bleeding, around 5 to 15% of them will come back with that diagnosis of having hyperplasia. Like I said, when it's without the atypia, we are more relaxed. However, we do still advise some sort of management to help the thickening reverse itself or kind of keep under control. And we usually offer this through the Mirena coil because it contains the hormone progesterone, and that really does control the lining of the womb. And to err on the safe side, what we do is we see these women every 6 months. We have the transvaginal ultrasound scan, and we just check that everything is going the way it should. And if something isn't, we can pick it up quickly in these women.
And once you were happy with the size of the womb lining, the thickening of the womb lining, and the progesterone treatment, the coil had worked, would you then take the patient off of the coil? Would you remove the coil or just leave it there in case it flared up again?
So the Mirena coil actually can be used as a part of hormone replacement therapy. So we would need to discuss with the patient if they're having any symptoms of the menopause. This could also help with that. I think getting the diagnosis hyperplasia without the atypia, we'd either recommend the Mirena coil or even progestogen tablets as well. With those 6 monthly scans, we feel that we're kind of keeping a check on them, but we're not escalating anything. They're still being looked after. The other type of hyperplasia, the atypical one, we like much less. So over a 10-year period, we say maybe 25 to 30% of these may develop the
big difference.
Massive difference. So what we propose to these women is first line, we would propose a hysterectomy, so surgical removal of the womb at that stage, because the stakes are a bit higher, right? If I say like 1 in 3 or 1 in 4 of individuals with that diagnosis can get womb cancer over 10 years. we can do the surgical procedure to make that down to 0.
Do you find that most people who you treat that have the atypical hyperplasia, do you find that most of them say, yes, give me the hysterectomy?
It really, really does vary. I think people are a lot more attached to their organs than I had originally thought, but I guess I'm sitting on the other side of it. I think it's normal for someone to be like, hey, that's it's a major organ, it's a major surgery, especially someone that's never had surgery before. They might be kind of reticent to going ahead with that. So we do recommend that, but equally we would never force or pressure a woman into doing anything with her body. So the other alternative is the Mirena coil or the oral progestogens, as I said, because at least we're doing something then and monitoring them with the ultrasound scans too.
And if somebody does have the atypical hyperplasia and is on the progesterone treatment as well, kind of if she were to be one of the people that did end up developing womb cancer, which is, as you said, like 1 in 3, 1 in 4, so not sadly unlikely, would you expect, sort of typically, I'm trying to kind of imagine the typical pathway for this, would she sort of have the coil for a couple of years, get some more bleeding, go back to her doctor and end up with a cancer diagnosis that way? Or what's the sort of typical pathway for this?
So the typical pathway is, by virtue of having these diagnoses, we would be scanning these women every 6 months. So regardless of whether they are symptomatic or not, we would pick it up by virtue of twice a year scanning them. Because I think that's how it gets picked up.
And so if somebody has got the hysteroscopy results and they say it's a cancer, if it's caught early, because I'm conscious of time, I want to get on to like another part of our discussion, but if a cancer is diagnosed early, is it likely that, like with the atypical hyperplasia, a hysterectomy can successfully treat the cancer if caught early?
Yeah, so we know that a big factor into how effective treatment can be is the stage of the disease and when the individual is diagnosed. Whether the cancer is contained in one location, in one organ, recovery and treatment is so much higher for those women. And as you've mentioned before, research has shown that women from minority ethnic groups do present in much later stages where the cancer has already spread, where there's other organ involvement, for example, the gut, the bowels may be involved, it may have spread, etc. And that does make things a lot more challenging. It requires a lot more different individuals in the team looking after the woman as well. But definitely kind of early catching of womb cancer, we can definitely offer kind of good treatment and good results for that woman.
But like we've both mentioned, this is stemming from the fact that people from these minority ethnic backgrounds are more likely to get a stage 4 diagnosis than stage 1, which is obviously a really difficult thing to deal with, and a sad fact. Does that kind of that fact directly echo in what you've seen in your clinics?
It sadly definitely does.
I wish you'd said no.
I know.
Yeah.
Me too. Yeah. As someone from a South Asian community, it is kind of deeply saddening and frustrating to see this because, like we said, so much of how effective treatment is depends on how early that cancer is diagnosed. And in order for that cancer to be diagnosed, the woman has to know, okay, what is my body normally like? Is this an abnormal symptom? Who do I talk to about it? Can I talk to my GP about it? And it's all those delays in kind of feeling empowered to talk about what's going on that essentially creates the big impactful delay in how late that cancer is when it's diagnosed.
And would you say, kind of from your own personal experience in your own community and seeing your patients from the same community as yourself and from Black ethnic backgrounds, would you say that there's a problem with people from these communities coming forward? Because, not to make this about me, Aayushi, but I had cervical cancer a few years ago, and I was diagnosed at a late stage 1 because I had my abnormal bleeding, and I just went straight to the doctor because I'm lucky enough to, for all of the many things I could list, feel comfortable, confident to go and do that. And it was caught early. Why is it that we're not seeing that same thing echoed amongst the different minority ethnic communities, that the rates are higher or the stage diagnosis is higher?
Well, firstly, I'm really glad that you went early.
I just had to mention, I was like, I can't let her go the whole thing about early diagnosis without talking about myself.
No, I am really glad. And I think you've mentioned it, you've mentioned feeling confident to talk about those symptoms, feeling like it was a safe topic to talk about, feeling like it didn't have stigma attached to it. It wasn't a taboo topic. If conversation about a topic isn't encouraged in the home or in the community, then how comfortable would someone be in discussing those details with a complete stranger, a GP or a nurse?
Of course. If they've never discussed it before with a mum or sister, how can you go from nothing to a stranger? It's a big, big jump.
It's a massive jump. So I think if there's any kind of take-home message, it would be to feel empowered that if you think that something is wrong with your body, if you are worried about something, tell someone. And that first step is telling someone you trust, someone in the household, someone in the community. And together we can encourage each other. Women can encourage women to step forwards. You can bring someone with you to an appointment if you don't feel comfortable in talking about it. If you don't feel comfortable in talking about your bleeding or painful sex or things that normally aren't kind of dinner table conversation in your household. And only by supporting each other can we prevent statistics like the one you mentioned at the start, and the one that unfortunately I see in clinical practice day in and day out.
I think that is a sobering but also very powerful and empowering, hopefully for people watching, note to end on. If you go backstage, I'll say bye to you personally, but from everybody watching, Dr Aayushi Pandya, thank you very much.
Thank you.
Thank you. The wonderful Dr Aayushi there. I think that was a really, really interesting conversation, and great to get an insight from somebody, seeing these patients, diagnosing people, hopefully ruling out wound cancer in most cases. As I said, thank you so much for watching this episode of Probably Nothing. We will be back next week, and I will be speaking to the wonderful Jackie about her own personal experience of a wound cancer diagnosis. I'm really excited to talk to her. I'm excited for you to see our chat, whether it's live or on catch up. So once again, thanks for watching Probably Nothing. See you next week. Stay safe.